Thanks, Amar. I want to thank everybody for the invitation. I am going to try to start really basic, okay? Because I think where we get hung up is doctor speak, and I'm going to try to avoid jargon. I want you to stop me at every turn, but we're going to go through a couple things. So we're going to go through basic anatomy just being structure. We'll talk about scoliosis broadly, and then some definitions specifically about what we're dealing with today, which is adolescent idiopathic scoliosis. And then we'll talk in detail, actually I shouldn't say detail. What I'm going to do is broadly again introduce the idea of surgical treatment. So I have some props, as you will see. So we will start really with the basics. Here it is, okay? This is a spine, all right? Can everybody hear me if I come here? Yeah? So vertebral bodies are these little blocks stacked up on top of each other, separated by this in front. You look down to where the little red thing is, that's the spinal cord. Okay. You look at the back, these are the things that you feel on your back. These are your spinous processes. And then God, happily for surgeons, put these little things called pedicles, which go from the back to the front. And actually, there's a tube of bone, which as you can see on that, you get a chance later, you can see it. But we put hardware right into those things called pedicles. Okay? So the language is fairly straightforward for spine. It's just the bodies, the pedicles, and the spinous processes is what you will hear us talk about, and the spinal cord. Okay? So very basic. Looking at a spine from the front, most people are straight. 10 degrees, maybe a little less. If you look at it from the side, and I'm going to make this look like this, but people have what's called kyphosis here, which you can see on the pictures there. And then the sway back thing is called lordosis. So if you watch us, we always focus on x-rays looking at them from the front. But if you're a surgeon, you want people to look normal from the side. It actually turns out to be more important that they're more normal from the side than they are from the front. Okay? That's a concept actually that's relatively new. It's only 20, 25 years old. Because old days, Harrington, people know what Harrington instrumentation was? Harrington was just stretching out in front. But if you took them and looked at it from the side, it also looked stretched out. You'll never see that now. Everything we do now is to stretch them out from the front, but to reform them from the side. So when you see them from the side, the x-rays are going to look like a normal spine. Okay? So important concepts. So we talked a little bit about that. So another concept, though, that I think is important to understand. So it's not just the spine, because your ribs are attached to your spine. Okay? And it turns out, other than the spinal cord, which is what we're most worried about, the lungs and the heart are the next most important things that we're worried about. Okay? Because the lung is sitting, you can see the picture, the lung literally lives in that cage that we call the thorax. Okay? If you feel your chest when you take a deep breath, this is a moving system. Your lungs are changing their shape and their position every time you take a deep breath. So if you can imagine, if you have your spine turned, the lungs here don't move as well, and the lung here is open up. So a lot of what we worry about in the future has to do with that concept. It's the fact that we're attached to the spine, to the ribs, to the thorax. Okay? And the outcomes that we worry about are related mostly to that problem. So scoliosis, by definition, is just a curve in your spine looking at it from the front. That's all that word means. It doesn't mean anything else in and of itself. We, as doctors, try to make it more detailed. The spine is three-dimensional. So it's hard to appreciate that when you look at x-rays. This is a three-dimensional structure. Okay? And when the spine does this, when it curves this way, it actually rotates as well. So it's three-dimensional in the sense that everything changes, not only looking at this way, but also this way. We use that to take that test you guys all did at school, the Adams forward bend test, it's called a bend. It harnesses the concept that if you have scoliosis, your ribs have rotated around the curve. So what we're looking at is not your spine wall, right? We're actually just looking at where your ribs go. And we're measuring. See that little thing called scoliometer? You guys seen that? That's a surface way to measure. That measurement different than the x-ray. So people get confused. Sometimes they'll say it's a 25-degree curve, and they mean x-ray measurement. But if you come to my office following you without an x-ray, I would say your scoliometry is about 7 degrees. Okay? So they match up to some degree, at about 7 degrees, 5 degrees in the scoliometer. It's about 25 degrees of an x-ray. So we use that to equate to an x-ray, but also talk about the three-dimensional deformity without taking a CAT scan or some fancier x-rays. And then the classifications. So scoliosis falls into 3 broad classifications. And then we'll talk about the most common one, which is idiopathic. But anybody here, there may be people in this audience, I'm not sure, but there are people that are born with congenital abnormalities. In other words, these bones, instead of being square, are wedged, or there's extra pieces of them, or they're stuck together. Okay? That's called congenital scoliosis, and that's a little different. The next most common group is someone who is really not neurologically normal for some reason. It could be anything. It could be a spinal cord injury. It could be trauma to the head. It could be born with something wrong with your nerves. We call that neuromuscular scoliosis, and that's a whole different crew. And then we deal with particularly what I basically think of as people who are neurologically normal but have a curve. So there's congenital. So I just want to, if you can see that, I don't know if it projects as well. Is there a pointer up here? I don't know. So if you look, there is an extra piece of bone right there. See it? You guys see it up there? So that child, you can't see it. So this child here has there's an extra piece of bone. But when you see an extra piece of bone in the spine, they might have something else wrong with their kidneys, or the heart, or the spinal cord. So it changes a little bit of how we care for them. Pointer right there. Neuromuscular disease is very common for us, and these are children who sometimes don't walk. So our goals are different for them. We often deal with their scoliosis, not to make them look straight and wear dresses nice, but to actually so they can sit in their chairs and have functional lives using their hands. Different group of patients with some different issues that are similar, but not quite what we deal with. This is what we're dealing with, okay? So this is a child who has scoliosis, but this is a group of kids who are totally normal, right? You guys all know this. Anybody, all of a sudden, you're 10 and someone says, hey, wait a minute, something's wrong with your back, right? So that's the group that we're talking about. That's called adolescent idiopathic scoliosis. Idiopathic, as you guys know, if you don't know, means we don't really know what it's from, right? The word idiopathic in doctor speak means, not that we don't have any idea, but it means we don't know what caused it, okay? So adolescent idiopathic scoliosis is what we are talking about generically in this group of, this meeting today. And it's in distinction to this group, okay? So there are kids that are little. You guys, some of you may have been very little. Less common in the middle is juvenile. And then there's the group of adolescents. So this is, to give you language, right? If you hear somebody say juvenile idiopathic scoliosis, it means they were diagnosed between 3 and 10. So, just a couple things. I'm going to use this generically as a way to understand how we talk about scoliosis now. So, X-ray measurement, right? And you're going to hear us talk about maybe a Cobb angle, which is a radiology way of measuring curves. And generally speaking, we break them into these categories. A mild curve is 10 to 25 degrees. A moderate curve is about 25 to 50, and over 50 degrees is relatively considered a severe curve. Now, there's obviously gradations past 50. But a lot of our recommendations, as you know, are based on that 50-degree number. We'll talk about why in a second. So, what are the real issues with this? Okay, so why does everybody get a little bit concerned? Why are parents freaking out when the school's note comes home saying that we found something on your child's school screen? What do parents think about it? What do kids think about it? But also, what do we worry about? So I'm going to try to give you pieces of all of those. Appearance really turns out to be a very key part of this, as you all understand. Okay? And it really, A, it's the first thing that drives you to us often, but B, it's the thing that you guys are most concerned about, at least acutely, especially as a team. Okay? So yes, we are concerned about it as well, but it turns out that some of those concerns, for example, that where your shoulder is or whether your scapula is a little more prominent, are much less painful and difficult to deal with when you're an adult. Because you realize that they're just mostly cosmetic things for the most part. Okay? So we appreciate the appearance part, but that's not really where our total focus becomes when we're dealing with this. Do kids have back pain? So that's always another question that comes up. Yes, but is it any worse than any other teen? Probably not. So when we think of scoliosis and back pain, it's less common than you would think. Okay? And the truth is, when we do hear it as a chief complaint very commonly, we worry that something else is going on and not scoliosis. Breathing. So we talked about this a little bit. But if you can look, this is an extreme example, but imagine that lung on the left side is just getting squished. When you do your scoliosis surgery, you're able to open it up and make the lung more functional. So the curved spine causes stiffness, it compresses the lung, and conceivably give you problems with your respiratory system. Okay? Now, that doesn't happen at 40 or 50, even at 60 degrees, but it can happen at 80 or 90 degrees. Okay? And it's a little bit variable with some children. So for example, if you have reactive airway disease, you're an asthmatic, you might be more sensitive to a smaller curve. Okay? You might be more sensitive to different changes in the shape. In other words, if you're very flat, some people get what's called hypokyphotic. It's very common. You have a very flat side profile. That can also change your pulmonary function. And then worsening. That's the thing that the surgeons are worried about. So how do we know which ones are going to get worse and how are we going to stop them from getting worse? That's really what we're all here to deal with. So even in braces, as we know, since we're not talking about braces in this session, but in braces we still see worsening. And those tend to get worse in the younger children who present with bigger curves, okay? Sort of a standard way that we think about it. But if you start out at age 10 and you have a very mild curve, there's a good chance in the next 3 or 4 ensuing years of growth that your curve's going to change. And then, we're actually very fortunate to have Dr. Weinstein, but this is really a very important idea. We know, after looking at adults 40 years after they were diagnosed with their scoliosis, that if they get to their adult lives and they have 50 degrees of curvature, that there's an almost 100% chance that they're going to get worse to some degree, okay? And on average, it's about a degree per year if you have it in your thoracic spine and your chest, okay? So in your head, do the math, right? If you're 20 years old and you have a 50-degree curve, by the time you're 40, you have a 70-degree curve. So the recommendation for surgery is mostly, not completely, but mostly based on that important concept. And of course, this is what all of us fear, right? You lose patients to follow up when they probably should have had their surgery and they show up at age 57 and they have pulmonary issues, back pain. So we're here today because that is not really where we want our kids to wind up. So just going through this, we'll skip to surgery in a second. So the bracing you talk about, but the curves. Let's talk about surgery because I don't want to get behind on time. Most commonly, we do what's called a spinal fusion surgery when your curve goes over 50 degrees. Spinal fusion just means you take this flexible thing that's curved, we straighten it, we take out these little joints, and then we lay bone across it, and we make it a solid piece of bone. Okay? So wherever that solid piece of bone is, you're not moving anymore, and you're not growing anymore. But you're growing below it, moving below it, you're growing above it, moving above it. Okay? So the kids who know that the lower we go, the stiffer you feel. A lot of our technologies and things are actually trying to limit the amount of fusions that we do and limit how much of the bone actually has to be fused. Okay? That's an important point. Then surgery. So this is our basic surgery is just exposing the bone, and then we put these things that are called anchors or pedicle screws. So you can see a model up there. I'm going to pass around this. I want you guys to actually feel these and see these. Okay, this is a tray. These are the rods. Okay. This is what we're talking about. This is the technology that we're using to correct the spine. We like to ideally fuse as low as we have to get balance, but we still want to leave some mobility, and that's an important idea. And then the title of this was, there's something for every curve. So there is not one operation that every single person gets every single time. Okay? So some people get short fusions. Some people get very long fusions. Some people only get fusions in their lumbar spine. And it totally depends on what your surgeon thinks you need and what your curve looks like. Okay? So when we've changed dramatically on this, we are very much into the idea that we tailor what you need based specifically on your child and not what everybody else gets. And then outcomes. So this again is part of this talk, and I'm going to switch over to Amr in a second, but we have gotten, I think, over the years, safer with our surgeries for lots of reasons. Technical reasons in terms of how we monitor people, how we do our surgeries, these study groups, these guys who do nothing but follow up our patients. So most people are safe through the operating room. They return to their activities. And as you'll see, if you get a chance to see the adult, some of the adult patients, they really have normal lives. Okay, you really got to focus on that. Even though they went through this very difficult time in their teenage lives, they really are normal adults, healthy, happy adults for the most part when they get to that stage. So number one goal, foster healthy adult life, and I think that's what we're all here for today. Okay. And then, Honor, do you want to talk a little bit about some of the future stuff, or jump ahead?
Yeah, go ahead. Sure. Yeah.
I'm just afraid I don't want you to run out of time.
Absolutely. Wow, Marty, that was great. What we'll do is I'll finish this talk up with a few more slides, and then we can field questions. But boy, you put a lot of effort into that. Thank you. Really good. So, some of the future trends that are coming through. Traditionally, in the past, if you were little, generally we would say less than 10 years of age, you have a lot of growth left. We don't want to go ahead and fuse your spine at that time because we don't want to limit how much that spine is going to grow. So we would do growing systems. And here, as you can see, whereas before, Marty had all these little anchor points up and down the spine. Here we've just got anchor points at the top and at the bottom of the spine. And traditionally what we would have to do is we would have to go back in for surgery every 6 months. And as you can imagine, that was really traumatic on a lot of our patients. Particularly also, there were also surgical risks that would increase in our patients as well if you're going back for surgery every 6 months. And I remember when we were doing a lot of these, and we got some people from our OR, they can tell you as well, some kids, when they knew that it was their time to go ahead and come back for repeat lengthenings, they would just try whatever they could to not come into the hospital. So we knew that there had to be a better way to treat these kids. And sure enough, a lot of work that Dr. Barnia and others did out in Europe, there was a big trial with this magnetic system, whereas now for these kids that are still growing, instead of having them come back for a surgical procedure every 6 months, you can actually come for an outpatient visit and just have a magnet placed that would allow your spine to grow. And for the patient that has a significant growth left, and a curve size that really fits the parameters for this device, this is a really a leap in our treatment of our patients. And Marty went ahead and touched on this, but if we were to think about what we've learned in the last several years and where we're going with all of this to really improve our care of our kids, our understanding of the spine in three dimensions has really increased over the last several years, and we expect a lot more understanding. And by this I mean, we assess our spines on two things. Obviously, we see how our kids look and we see how our x-rays look. But these x-rays that we take are really a two-dimensional representation of something that we all know is in three dimensions. So we really, although we've had some assessment of what these curves are doing, we really didn't understand them or don't understand them in three dimensions. And here's just an example of this. So if you take a child and you just have them stand straight up and you shoot a lateral x-ray, this is what it looks like. And if you take a look, let's see if I have my pointer. If you take a look, this is that side view that Marty was talking about. It almost looks like the child has some kyphosis. If we go ahead and change that view to shoot the x-ray now in line with how that curvature is, it looks a little bit straighter. But if we really do a true three-dimensional understanding of what that spine looks like, take a look here. Here's the front, here's the back. Now the spine is actually, if you really, in its true position, is actually very lordotic or hypokyphotic. It actually really sticks in. And Peter Newton, over the last several years, has really led the charge for us to understand what the spine really looks like in three dimensions. And a lot of that work is done with one of our sponsors using the EOS machine. And now that will really help us decide not only what's the optimal treatment, but how we are doing with our treatment. As you can imagine, if we're assessing it using 2Ds, we're doing that pre-op and post-op. Now we'll start getting a much better understanding of how we're doing in closer to a three-dimensional perspective. The whole concept of growth modulation, these are kids that we're treating and kids that have growth left. So how can we perhaps use that growth to further our further improve the procedures that we perform on these kids. And this isn't a new concept. It's been utilized throughout the body. We know that if kids have crooked teeth, we can, and they're young, we can use orthodontics to really help help develop their jaw and help their teeth line up. We also know, both of my sons actually had this. I still remember when they're 3 or 4 months old, really a flat head on one side. And over the span of a few years, you could, really see it reform. So we know that the body, while it's growing, has this ability to really reform and to balance itself. And, an area, as many of you know, that we're very interested in is how can we go ahead and apply that to the spine? And this concept has already been extensively studied in the preclinical setting, and it's still going to require future work and longer follow-up to really understand how it works in the clinical setting.